So we start soon.
Okay. So good evening. My name is Dr. Shakti, and we are going to understand a little bit about hemostasis today. Okay. So we so far covered various topics in hematology, and this is by far one of the most important as a whole. Okay. The other important topic was erythropoiesis. And apart from that, this is one topic, the entirety of which you should never go for the exam without studying, because this is that important a topic. And often questions are being repeated from this. Okay, so taking a look at these questions, you will have somewhat of an idea as to what sort of questions will come and what needs to be given more importance to. So as a long essay, obviously the entire hemostasis can come. They'll ask you about the role of the coagulation cascade by itself, whether it is the intrinsic pathway, the extrinsic pathway, or it is the common pathway. Okay, so that is one question. A long essay, the entirety of the physiological process of hemostasis will come. Second, a short essay. So one is what are the functions of platelet, especially in hemostasis. Then the various laboratory tests that are involved and that are important for coagulation disorders. So what are they? How can we differentiate between them? What is the normal value? We'll go through that. Then we have the fibrinolytic system, which is at the end. Apart from that, very short answers. What are the different types of granules in a platelet? What are the functions of it? What are the constituents of it? That is one question. Clinical questions like what is hemophilia? What is von Willebrand factor? Questions like that can come. And of course, again, the clinical application regard to how anticoagulants work. So with a few examples, you can mention what are anticoagulants and how do they work, because each of these anticoagulants work in a different fashion. Okay, so you go through all of this and that pretty much makes up what you need to understand in this topic. So starting off, how do we define hemostasis? Hemostasis is the physiological process of preventing blood loss. Okay, so anywhere there's some injury in a blood vessel. So a damage is there in the blood vessel and we need to prevent the blood loss. And in doing so, we have to try to make sure that the entire of the blood does not coagulate. Instead, only that part should coagulate and the rest of the blood should be in a free flowing form. That is the entire physiological process of hemostasis. Okay, so hemostasis is a physiological process of preventing blood loss while maintaining blood in fluid state within a damaged blood vessel. So first off, a short note on what is platelet, because questions of with a neat label diagram, draw and explain the structure of platelet. So what you have to understand, platelet are just fragments. They are no nucleus. They are fragments of your megakaryocyte. Okay, the megakaryocyte breaks down into pieces, and around 1.5 to 4 lakh cells per microliter is the normal level. And it usually has a lifespan of 7 to 10 days. Now, when you talk about the structure of your platelet, it is usually in an unstimulated state, it is elliptical in form, okay? And it has a membrane, and outside the membrane, it has a glycocalyx layer, okay? And it has microtubules on either end. So when you're drawing this, make sure to draw it like this, elliptical shape with a bilayer membrane outside which a glycocalyx is there and microtubules on either end. Apart from that, you should have glycogen reserve for energy, okay? Because this does not have a particular nucleus per se, mitochondria, all that is not there. Then we have a lysozyme and microperoxisomes as well in it. Now, most important thing you have to understand about a platelet are that it has specific type of granules in it. Two types that you need to know. One is a dense granule, the other one is an alpha granule. So we got the alpha granule, we got the dense granules. And we have to draw a particular system like this, which is called a surface canalicular system. So this is one way by which things from the granules here can get released outside. Okay. Apart from that, even your glycoprotein 2B3A, which we talk about later in aggregation, is also coming out through this. So in various ways, things from the inside can be given outside with the help of this. Okay, so this is a surface canalicular system. And apart from a surface canalicular system, there is also a dense tubule system which is there. And this acts as some way of calcium storage mechanism. So calcium storage, dense tubules are there, surface canalicular system is there. We have the alpha and dense granules. And microtubules on either end. You have the lysosome, peroxisome, glycogen, and glycocalyx. So remember that question which we were talking about earlier, the two granules, what are the components of it? What are the constituents of it? What is the function of it? So in dense granules, there is not much you have to think of. You can think of ATP, ADP, calcium, and serotonin. Okay, so calcium, which is required for your homeostasis mechanisms. On top of that, we have ATP for energy, ADP, and serotonin. Okay, so these are structures which are there inside your dense granules. So this ATP, serotonin, and all act in certain ways for helping in activation and aggregation steps. Calcium is also involved in hemostasis, especially in the coagulation cascade. Okay, these are the functions of all of this in a platelet. Apart from alpha granules, remember we have a dense granules, we also have a alpha granule. So the alpha granules have constituents in them which are there in the plasma as well. It's not exclusive to be produced from your platelet. So for example, fibrinogen, which is formed from your liver. So fibrinogen, which is there. Then your von Willebrand factor, which is also released from the endothelial cells. We have factor 5. So all of this also, which is from the liver, but can also be released by your platelet. Okay, and albumin, which is there, but does not have a hemostatic function. But ultimately, the main source is the major involvement for hemostasis for these components, not the platelet. Platelet does not, for von Willebrand factor. Platelet is not the major source of von Willebrand factor. Please keep that in mind. Okay, so we have fibrinogen, von Willebrand factor, factor 5. On top of that, what else is there? Things that are not present in the plasma otherwise. So one important example is thrombospondin. Thrombospondin is something, once the platelet plug is formed, comes and stabilizes that platelet plug. Okay, so once the platelet plug is formed, it comes and stabilizes the platelet plug. Okay, so that is thrombospondin. Apart from that, we have beta thromboglobulin, which is also in some ways helping in mitogenesis and all that. We have three things: the platelet-derived growth factor, transforming growth factor beta, and platelet factor 4. And they act as chemoattractants to make things come towards it. Okay, so we have PDGF, TGF beta, platelet factor 4. If you can remember, you can think that platelet-derived growth factor also helps in promotion of fibrosis and wound repair. Okay, TGF beta has a negative feedback role on thrombopoietin. Platelet factor 4 helps in platelet activation. Okay, so that is acting as one of the markers for platelet activation, especially when the granules are released over there. Then, of course, beyond that, when there is a rupture of a blood vessel, one of the things that needs to happen is make sure the new blood vessels are forming. So neovascularization, we have vascular endothelial growth factors. And in helping to bind to the thrombocyte, the platelets, we have fibronectin, which helps in act as a surface for it to adhere. So like that, alpha granules contain your thrombospondin, beta thromboglobulin, PDGF, TGF beta, platelet factor 4, vascular endothelial growth factor, fibronectin. Okay. So that is to answer that question of what are the constituents of your platelet, the granules which are then the platelet. Now remember, there was another question: what are the functions of platelet? So the various functions of platelet with regard to your blood coagulation whole cascade. The initial steps are where platelets are coming into the play. Okay, So the initial steps are where platelets are coming into play. So what are the platelet functions you have to discuss about? One, how it helps in adhesion, then activation, shape change, aggregation. Also later, platelets act as a medium on top of which coagulation cascade can act. So without a platelet phospholipid, the coagulation is difficult to even happen, even if the uh, things that are required for coagulation is present. Okay, so we have the various platelet functions that we are talking about. Okay. So you can see here, this is the endothelial vessel, and in the endothelial vessel, there are endothelium cells which are there, underneath which the basal lamina is there. Okay, so when there is some sort of injury, say for example, something is coming from here and injuring this area. Okay, from the outside, this area is getting injured. What will happen as a result of that? That endothelial layer is damaged. So because of that, what is going to happen is things which are there underneath it. Okay, like this, this basal lamina will start to get exposed now. Okay, so the first thing that happens is not platelets. Instead, in order to control bleeding, the first thing that happens is vasoconstriction. Nervous mechanisms have been known to play a role in it. Local myogenic, as well as the release of vasoconstrictors are also known to play a role. Okay, so first thing that happens is vasoconstriction to make sure that bleeding does not happen much. How does that happen? One, by nervous signals. Two, one of the things that they talk about is a local myogenic reflex, something to do with a pulling of some strands, which will open up a calcium channel, resulting in constriction. So that kind of a local myogenic reflex is one thing that happens. Then, of course, we have vasoconstrictors which are involved over here. Okay, that especially platelets by itself can play a role. Certain things the platelet releases acts as vasoconstrictors. So take a look at this question. What role do platelets play in hemostasis? There are various options. Secrete antibodies to neutralize pathogen, that cannot be the answer. Aggregate to form a temporary plug at the site of injury, that also cannot happen. Produce fibrin, so produce fibrin for clotting process, that also cannot happen. Phagocytose bacteria during infection, that also cannot happen. So ultimately, the things that we're talking about, your adhesion, activation, aggregation. These are various things that are related to platelet. So this is going to be the answer for this question. Also, can I just ask, am I audible here? Because there's a lot of noise from the rain here. So I just want to know, confirm if I'm audible. Can I just get a confirmation? Okay.
Yes,
All
sir.
right. Okay. Okay. So now what we're going to understand is how does that happen? So one of the first thing that has to happen is your platelet. Your platelet, which is going to be here. This platelet is going to be here. And the platelet by itself will come towards this and can attach to the collagen directly through a particular GP6. Okay, it has on its membrane the phospholipid. GP6 is there on top of the platelet. If that is present and it is a slow moving blood area, then it can directly attach to collagen. But most of the area, there is fast blood flow. It cannot directly attach to the basal lamina, collagen, and all directly. So that is where there is requirement for a separate substance that is released from your endothelium, which is called a von Willebrand factor. Von Willebrand factor, which is released directly. So this von Willebrand factor that goes, attaches itself over here like this. That has acts as a braking mechanisms for your platelet to now come and attach over here. So how does this attach? It attaches through GP1B. Okay, so we have GP6 to directly attach, and we have GP1 to attach to von Willebrand factor. Okay, so now that this happens, your von Willebrand factor is here. Attached to that, a platelet is there. So this step, what is called your step of adhesion. This is the first thing that happens. Adhesion happens first. For that, either directly with the collagen or through von Willebrand factor it can enter. Now, once adhesion happens, by the interaction between your GP1B and your von Willebrand factor, there is the next step, that is activation. Okay, so there are different mechanisms. One is a phospholipase C mediated mechanism is there. Okay, so through a G protein coupled activity, a phospholipase C activity happens. So ultimately, because of that, IP3 DAG is released. So these IP3 and DAG, what does it do? IP3 from the dense tubule will release your calcium. DAG will result in a lot of steps whereby your platelet changes its shape. So DAG will result in your activation of your actin-myosin complexes. IP3 will result in calcium release. So because of the combination of these two, the shape of the platelet now changes to become like this instead of what we saw earlier, elliptical. So your elliptical platelets now become like this, where it has multiple pseudopods on it. Now what happens? This activated platelet will further release structure. Degranulation takes place. Okay, so shape change happens. Degranulation happens. So degranulation as a alpha and dense granules will release. So as a result of this, the components from this can now release itself, go sideways, and neighboring platelets, which have not yet attached to von Willebrand factor, can also get activated. Okay, so we have a platelet which results in adhesion followed by activation, and it changes shape and it releases substances which can further go and activate nearby platelets, resulting in all the nearby platelets to change the shape. Now these nearby platelets which have changed its shape. Okay, so these nearby platelets which have changed shape will be linking to other nearby platelets. That is where you need GP2B3. So earlier we talked about GP6 and GP1. Now we are talking about GP2B3A. So what does GP2B3A do? All the activated platelets are going to connect to each other through GP2B3A. This step is what is called your aggregation. So remember that MCQ we just talked about. So GP2B3A helps all your platelets which are nearby to get activated, after which they are going to now form aggregations exist. So multiple platelets will come together and aggregate. So this aggregation that we just have, this is what is called a temporary hemostatic flux. Okay, so this is the first thing that happens. So when there is, for example, you're taking a pin and you're puncturing and causing a bleeding. Okay, that bleeding will go on for a little time until a point where bleeding stops. This is what is called bleeding time. So for bleeding time, what is happening? From the time the vessel was injured till this aggregation resulted in a temporary hemostatic plug formation. That is what is bleeding time. So you understand? In bleeding time, nowhere is any coagulation factor is involved. In all of this, only platelets are involved. So that is why you have to understand bleeding time is dependent more about your platelets. If platelets are less in number, platelets are not functioning properly, then bleeding time gets prolonged. When coagulation, the factors which are required are not there, then coagulation time is prolonged. So this is one key difference you need to understand between your bleeding time and coagulation time, clotting time. Okay. So what happens? Adhesion, activation, shape change, degranulation, aggregation. Now, once aggregation happens, one of the things that happens is okay. So this is just a representation of what I was explaining earlier. Fibrinogen, which is there. Okay. Temporary hemostatic flux is formed. And we talked about the bleeding time. So how do you define bleeding time? It's the time interval from the puncture of vessel wall to when bleeding stops. This is very important when you're talking about your practical system. Okay. Then we have what are the methods that which we normally use? Duke method is what we usually use. And according to that, the normal time is 1 to 6 minutes. Okay. In case you're talking about IV method, it is slightly longer because we're making a bigger wound actually. Okay. So in that you're putting your mercury, your BP cuff, and then increasing the pressure, then making small cuts on your forearm. So it will take longer for the bleeding to stop over there. Okay. Next is understanding your coagulation cascade. So till now, these are the functions of platelets. So when a question of what are the functions of platelets comes, you can talk about all of these spaces here. Okay. Now, your coagulation cascade. For that, you need to understand what are the clotting factors. Clotting factor 1 is fibrinogen. 2 is prothrombin. 3 is tissue factor. Remember these names at least. 4 is calcium. 5 is labile factor. Now 6, if you notice, is not there because earlier what they discovered as 6 was actually just activated factor 5. Okay, then they removed it from the nomenclature so that the rest of the things don't get confusing later. They kept the nomenclature the same. So that's why 6 is no longer there. Okay, so we have fibrinogen, prothrombin, then tissue factor, and then 4 is calcium. Then labile factor is factor 5, factor 6 is not there, factor 7 is stable factor. Then we have your factor 8. 8 is anti-hemophilia factor A. Okay. Then 9 is anti-hemophilia factor B. Then 11 is anti-hemophilia factor C. So 8, 9, 11 you can think of hemophilia A, B, and C. 10 in between is what is called Stewart-Prober factor. 12 is Hagman factor. Now, beyond this, we also have a fibrin stabilizing factor, which is factor 13. Now, these are all not the only things that are required. So, students usually, based on their knowledge from 12th standard, only write this much. But please know, beyond that, you have to write these remaining things as well. You have high molecular weight, kininogen, prekallikrein, kallikrein, and even your platelet, the phospholipid on the platelet is also considered as a clotting factor because it plays a crucial role in your coagulation cascade, because that acts as a surface on which everything can happen. If that surface is not there, coagulation cannot really take place that well. Okay. Now, another thing that you have to know is, usually in my MCQ, this question comes, which are the vitamin K dependent clotting factors. So factor 2, 7, 9, 10, and something called protein CNS are factor uh, vitamin K dependent in nature. Okay. So what they do is, with the help of vitamin, what they do is, there is a second carboxy group at the gamma carbon. Okay. So at that particular residue, there is a second addition of carboxy group which is there. So the importance of this is, when this is added like this, for that vitamin K is needed. That is how it gets activated. This acts as a attractor for calcium. So this domain we just added, that acts as a strong attractor for calcium. This is important because if you just have to think about all the steps where calcium is involved, you do not need to by heart. You just have to remember these. Anywhere these factors are involved, that is exactly where calcium is required in your coagulation cascade. It is as simple as that to remember this. Okay. So here you can see, it looks complicated. I'll just simplify it. So we have a reduced vitamin K first. Okay. That reduced vitamin K will result in gamma glutamine carboxylation. Exactly what I was talking about here. Okay. This thing that we are talking about is done by a reduced vitamin K. And in the process, it gets oxidized. And what does it do? It activates all of these factors. And in doing so, there is a particular enzyme which is vitamin K reductase. That enzyme brings this vitamin K back to its reduced state so that it can do this again. So there's a particular drug, like for example, warfarin, which we take. That warfarin, what does it do? It inhibits this stage. This vitamin K reductase is inhibited. So all the vitamin K related clotting factors cannot be activated. So wherever they are required, that coagulation is affected. Okay. So when we talk about your coagulation cascade, there are three things we have to talk about: intrinsic pathway, extrinsic pathway, and your common pathway. So ultimately what happens? Your prothrombin becomes a thrombin. Okay, the prothrombin becomes a thrombin. Your thrombin now acts as an enzyme which goes and splits fibrinogen to fibrinogen monomers. And ultimately it forms fibrin fibers. So this is what eventually has to happen regardless of extrinsic or intrinsic pathway. So we have prothrombin which is there. Prothrombin becomes thrombin. That thrombin acts as an enzyme which goes and converts fibrinogen to fibrinogen monomer, which finally becomes fibrin thread. Okay. So what happens? Remember the structure here. Now the fibrinogen, which is here, will come and combine over here. And finally, that should somehow get converted to a fibrin thread like this. So remember earlier, without the fibrin thread, it was called permanent hemostatic plug. Now, with the fibrin, it becomes tightened even further to form a permanent hemostatic plug. So how does this happen? We already talked about the common pathway. Prothrombin becomes thrombin. Thrombin now converts fibrinogen into fibrin. Now, for this to happen, there are two ways it can happen. First is what is called extrinsic pathway. Next is what is called intrinsic pathway. So just remember, the name is a little ulta. What is happening inside the body is called extrinsic pathway. And what is happening usually outside the body is called intrinsic pathway. Okay. So to simplify, two things happen. One, this injury which happened over here, this injury will release a particular substance which is called tissue factor. Tissue factor is factor 3. So factor 3 is being released right because of the injury, as a result of which this tissue factor will now go and activate factor 7. Okay. And with the help of factor 5, this whole process will activate factor 10. So this is the start of the common pathway. Ultimately, factor 10 gets activated, and that factor 10 will activate thrombin. Rest of it is the same. So here what happens? There is a damage to a tissue. Tissue releases your tissue factor. The tissue factor which is released will activate factor 7. So the tissue factor, factor 7 plus your factor 5 together will activate your factor 10. The activated factor 10 will now go and activate your prothrombin to form thrombin. So this is your extrinsic pathway. This is a much faster thing that happens inside the body. Okay. Also remember, initially this is a little slow, but once thrombin starts forming, this will result in a positive feedback where thrombin can by itself go and activate your factor 5. Initially, it is partially activated. Thrombin will now go and activate factor 5 to make it move faster. So here's a question: which are the following factors initiate the extrinsic pathway of coagulation cascade? So here the answer is factor 3. So this is what is called tissue factor. So this is where you have to understand a particular testing, which is called prothrombin time. So in prothrombin time, what they do is they give this thing called thromboplastin. That is a combination of your, factor 3, factor 7, your fibrinogen, prothrombin, all that into the system. And see how long it takes for the clot to form. Okay. So that is what is called thrombin time. So this is usually lasting around 11 to 16 seconds. Okay. The importance of this is when you give these components, these are actually detecting vitamin K dependent mechanisms. Okay. So what happens is you give your tissue factor. You start it off by giving a tissue factor. When you give a tissue factor and you start the system, okay, this is given and you start the system. Then if the body has this, this, coagulation will take place normally. In case any of this is not present, then this prothrombin time will be prolonged. So in a way, the prothrombin time is detecting what exactly? Your extrinsic pathway as well as your common pathway. Okay. And out of this, your factor 7, factor 2, factor 10 are all involved with vitamin K. Okay. And especially when you take oral anticoagulants, these steps are affected. Remember warfarin I was talking about? So whenever you take oral anticoagulants, these steps are affected. So for example, when you're taking oral anticoagulants to know if this is affecting your body and your extrinsic pathway is getting depressed and more bleeding is happening, then prothrombin time will be prolonged in that situation. Okay, so you just put factor 3 and start the process. And if these things are normally present in the body, then coagulation will take place. Okay, if they are not present, then problem will happen. Now, another problem started for people. In different parts of the world, the factor 3 which was used was not standardized. The prothrombin times normal value kept changing according to that. So WHO made a rule to utilize a standardized thromboplastin, and that is what is called PTINR. Okay, so that is what is called PTINR. You're just standardizing it. Okay, so based on that, normally the value should come to around 0.9 to 1.3. When you take warfarin and all, it comes to 2 to 3 and all. People who are having bleeding disorders and all, it can go up to 4 to 5. Okay, so this is about your prothrombin time. I'm talking about all this because question comes about the different factors which are and the tests which are there. Now, next thing that can happen. So say, for example, I take this blood. I take it in a test tube. You do this test that you do where you break the capillary. That is how you detect. So in that instant, what happens? Your blood comes into contact with certain substances like glass, silica. Okay, so that contact activates certain things, which is called your contact factor. So factor 12 is called contact factor. Okay, so once contact factor is activated, 12 will activate 11. 11 will activate 9. Okay, 9 in the presence of 8 will activate 10. So ultimately here you can see some similarity. Earlier, we have 7, which activates. Okay, and in the presence of factor 5, it goes and activates factor 10. Here what happens, factor 9 is activated. In the presence of factor 8, it goes and activates factor 10. And beyond that, it's the same process. Okay, even inside the body, this can, not only in this mechanism through silica, even this contact factor comes into contact with the collagen layer which is there down. This whole process can take place. Okay, so these are the various steps which are there: factor 12, 11, 9, 8, 10. Also, you have to understand there's something called a revised model where the thrombin by itself can go and activate factor 9, sorry, not 9, 11 directly. So even without any contact factor, it can directly go and activate factor 11. Okay, so I want you to do a small homework for me. So far, I've been talking a lot of thrombin, how thrombin does various things. So I want you to write down, after the entire class, think about what all thrombin does, because questions come on what are the functions of thrombin, how it is procoagulatory and anticoagulatory at the same time. Okay, so I need you to remember these different points from different places I'm talking about. 1, it activates factor 5. 2, this over here. Okay, like that, there are many things that thrombin does that I want you to write it down separately because questions come specifically and textbooks are not giving it properly. So again, the same thing that we're talking about. Okay, so we have the intrinsic system and we have the extrinsic system. Just know intrinsic system is fast, 12 to 20 seconds. Extrinsic system takes around 4 to 8 minutes. Okay, now at the end of this, the thrombin, fibrinogen, fibrin which is formed, that fibrin thread has to be stabilized even further by cross-linking it. That is where you need a particular factor 13 which is there. Even that, the thrombin can go and activate this process. Okay, which molecule is primarily responsible for stabilizing the fibrin cord during final stage of coagulation? So here, the answer is factor 13. Now, the next thing. So we talked about bleeding time. We talked about prothrombin time. We have to talk about activated partial thromboplastin time. So first we'll talk about what is partial thromboplastin time. So here what do? We actually give some substance like silica, glass. Okay, take the blood, put it in a mixture where glass, silica is there. So contact factor should get activated. Okay, And then what should happen? Your entire intrinsic pathway should happen. Intrinsic pathway happen, and finally your common pathway also happens. Okay, so for that we need all of these components. Now the problem is it becomes a little difficult to differentiate between whether a intrinsic pathway problem is happening or a common pathway problem is happening when you do only partial thromboplastin time. So that is where you give all of these components along with it. Okay, so not only are we giving glass silica, we're also giving the things that are required for your common pathway. So if the prolongation is happening, it is only based on problems in any of these which are needed for intrinsic pathway. That is what activated partial thromboplastin time is. Okay, so in activated partial thromboplastin time, usually it takes around 35 to 40 seconds. Okay, and you should also know that whenever you give a substance like heparin as an anticoagulant, it often goes and affects these. Okay, so earlier oral anticoagulants will affect vitamin K dependence. So it is better to use prothrombin time. Okay, when we use something like heparin, which is usually given as IV, then it is better to check with APTT. Okay, this is also called APTT. So which test is used as the intrinsic pathway? We just talked about it, APTT. Now there's something called clot retraction which happens. So after all of this process, okay, the fibrin thread which is formed, now the blood cells are there, RBCs are stuck, WBCs are stuck, platelets are there. In that, a lot of blood is there. A little bit of plasma is also stuck along with it. Now what is going to happen is around 40% volume of this shrinks down. Okay, around 40% volume of this shrinks down. And what comes out now is serum. What is serum? Plasma which is devoid of these coagulation factors. So since clotting took place, all the coagulation factors are utilized, which are there in your plasma, especially fibrinogen, for example. So when they're all used up, now devoid of these clotting factors, the plasma which is coming out is what is called serum. Okay, so for that, what happens is, your thrombostatin, actin, myosin is all utilized. And here again, thrombin can accelerate the step. Okay, and this usually takes around 20 to 60 minutes. So even after a clot is formed, permanent hemostatic plug is formed, clot retraction should take place. Short note on this can sometimes come. Okay, so finally, what is clotting time? Clotting time is the time from the puncture of vessel wall to when you get a fibrin thread. Okay, so remember bleeding time, that is when bleeding stops. So inside what is happening? Your temporary hemostatic plug was formed. In clotting time, what is happening? The fibrin thread will come only when the permanent hemostatic plug is formed. The clotting time is the time from the puncture of vessel to when the fibrin thread is finally formed. Okay, so normally we use a capillary glass tube method. Around 2 to 8 minutes it takes. Okay. Now the other part. So clotting is happening. Now a lot of questions can come from this. So one short note is, what are the factors that prevent clotting to happen unstimulated? So in our body, why does clotting not happen? Platelets are all present. Okay. So one thing, the endothelium is smooth. Remember, only when damage is happening, breakage is happening, that is the only time we see that the smoothness of the endothelium is disrupted. So normally the endothelium is remaining smooth. One thing. Glycocalyx also is present on top of the endothelium to make it smooth. Okay. So remember we are talking about thrombomodulin. That thrombomodulin also decreases thrombin. Okay, one thing. Second, the thrombomodulin thrombin complex. So thrombin, what does it do? Till now we were seeing that thrombin was resulting in more coagulation. But The thrombin, along with something called thrombomodulin, can go and activate plasma protein C. What does this plasma protein C do? This plasma protein C can go and act as a competition to factor 8 and factor 5, which are required for activation of coagulation cascade. Okay, and in turn prevents coagulation. So thrombin is not only pro-coagulatory, this is acting as anticoagulatory as well in this scenario. So unless stimulated, this should not result in coagulation. Okay. Apart from that, your endothelial cells also release prostacyclin, for example. And then we have two things: plasminogen activators, plasma proteinase inhibitors. What are these? That is what we're going to do next. Okay, so just note down these points. These are what you have to discuss when talking about preventing unstimulated coagulation. So can you see here? Now a clot is already formed here. Okay, so thrombin is here. So what happens is, usually thrombin goes and sticks to inside the clot. Okay, thrombin will not go, keep roaming outside in its activated form normally. Now there is a particular substance called antithrombin 3, which is released from the liver. These antithrombin 3, which then goes to the endothelium. That means not the broken part, but normally acting endothelium where no damage has happened. So when antithrombin 3 goes to an area which is normal endothelium, it will bind to a particular unit and activate itself. This antithrombin 3 can inactivate whatever thrombin is coming free away from the clot, so that coagulation will not happen outside here and there. So this is one thing, antithrombin 3. So in our body, normally, your basophil mast cells and all release heparin. What does heparin do? It increases the effectiveness of this antithrombin 3. That is all it does. Okay. So antithrombin, this heparin is also produced from outside, which can be injected. And when it is given, what does it do? Antithrombin 3's activity is improved, which inactivates thrombin. So it not only inactivates thrombin, but also these factors as well. So that is why your heparin, as I was telling you, plays a role in your activated partial thromboplastin time. They are more related. That is one thing. Okay. Second thing is what is called plasminogen. Okay. So in our body, there is something called plasminogen. This plasminogen can get activated by certain components which are called plasminogen activators. This plasminogen activators are of two types. Okay. So this is a major one. This is tissue plasminogen activator. There's another thing which is called urokinase plasminogen activator. So we have TPA and UPA. These plasminogen activators can go and convert plasminogen to plasmin. But there's something here. They preferentially activate the plasminogen which is bound to fibrin. Okay, so plasminogen which is flying around here will not get activated, but the plasminogens which are bound to this complex over here, they get activated. So what does this plasmin do? This plasmin converts the fibrin and breaks it down to fibrin degradation products. Okay, so this is ways by which your clot can eventually get lysed. So it's not like clot is there, it's remaining for the rest of your life. Once the hemostasis function is done, that clot should be slowly removed. Okay, that is also part of the body. That is what is called fibrinolytic system. Okay, so if a short note on fibrinolytic system comes, one, you can talk about this plasminogen. Okay, so plasminogen requires to be bound to the fibrin to be activated by plasminogen activator. Okay, this plasminogen activators convert plasminogen to plasmin. What does plasmin do? It breaks down the fibrin to give fibrin degradation products. Okay, now in case any sort of plasmin comes out, escapes from here, it should not go here and there and destroy other things. So what should it do? There is an alpha-2 antiplasmin which is available, which can inhibit that plasmin. Okay, and there are also in our body this plasminogen activators inhibitors also. Okay, so where does this come in play? So there are certain drugs like streptokinase, anti-streptase, urokinase, which can be utilized. So clinically, imagine situations where a clot is formed when it is not required. And this clot is causing an obstruction, blood flow is obstructed, resulting in damage to an area. This is what is called MI. If this happens in heart, that is MI. If it happens in the brain, it results in stroke. So in these scenarios, immediately if you want to break that which has been formed, you can use a plasminogen activator. Okay, so these plasminogen activators actually cannot, distinguish fibrin-bound and circulating plasminogen. It can result in a systemic lytic state because of that side effect. Okay, but in an emergency like that, you can use this. It was used. But now what we realized, we found out more recombinant varieties of tissue plasminogen activators. Okay, one example is alteplase drug. Then there are recombinant derivatives like tenecteplase, retiplase. Okay, whatever you can remember, you try to remember. Then even newer ones like desmotiplase, alpha-amiplase, these things are there. So what do they do? Whatever blocks are formed because of some thrombus formation, they will go specifically bind to that and break it. Compared to older ones like this, which are going to destroy any clot anywhere. Okay, which is not that good a thing. So another question that can come, explain the role of anticoagulants in the prevention of thrombus formation. And give examples of commonly used anticoagulants. So these are the various types of anticoagulants used. These are the different headings that we are talking about. One, antiplatelets are there. So remember platelets. Platelets have a very important function in your whole hemostasis. So either you can go and block the platelet function. Okay. There are ones that inhibit factor 10, which is activated. There are ones that inhibit thrombin. You can specifically go against vitamin K. And of course, the heparin that we were talking about, which activates antithrombin. So here are examples of that. Okay. So aspirin goes and inhibits a particular thing called thromboxane A2. Okay. So remember prostacyclin I was talking about earlier when we're talking about things that prevent unstimulated coagulation. So that prostacyclin in one of the steps becomes thromboxane A2. Okay, and this actually helps prevent your coagulation. Okay, the initial steps of your adhesion, aggregation, activation, that activation step is prevented. Okay, so that is one thing which is there. So aspirin can affect that step. Two, clopidogrel. Clopidogrel goes and affects the GP2B3A linkage, that aggregation step that is affected. Okay, factor 10A inhibitors, roxaban is an example. Now, thrombin inhibitors, things like pyridine, dabigatran, bivalirudin are examples of thrombin inhibitors. Vitamin K antagonist, warfarin. So this example we already talked about. You already know how it acts. It is acting by inhibiting a vitamin K reductase. Okay, and then heparin, what does it do? It increases the effectiveness of antithrombin. So now you have examples of the different types of your anticoagulants and how they act. Okay, now lastly, a very brief thing that you need to understand about your clinical application. Two things, hemophilia and von Willebrand disease. You need to differentiate these two. So hemophilia, A, B, C is there. More importantly, A and B is there. That A and B are X-linked, which means when you look at the history, family history, the males are affected. Females are usually carriers. Okay. Von Willebrand disease, on the other hand, is autosomal. Since it is autosomal, it can affect both males and females. You know, there are different types of von Willebrand which are autosomal. So it can be autosomal dominant also, recessive also. Now, another thing you need to understand, there are three types: type 1, type 2, type 3. Okay. So when a quantitative problem is there, which is partial in nature, that becomes type 1. When a quantitative problem is there, which is complete absence of your von Willebrand factor, that is type 3. When, you know, partially it is less in number, it is type 1. Now, there is one particular variety of von Willebrand disease, which is type 2, which is called, which is actually because of a qualitative. So, number of von Willebrand factor is not affected, but the quality of the von Willebrand factor is not functioning properly. Okay, so this will help you answer the next question that I'm talking about. Which coagulation disorder is associated with qualitative platelet defect? Not really that a good question, because, you know, quantitative problems are also there in von Willebrand disease, but only in type 2 type of von Willebrand disease, a qualitative defect is there. So the answer is von Willebrand disease over here. Okay, so if there is any doubt regarding whatever I discussed so far, please do let me know. Okay, and let's talk about, you know, Auricle. So Auricle has recorded classes, live classes, practical sessions, exam modules, and even hard copy books as which are made available. So these recorded classes are there, which has pre-recorded sessions, which give a thorough input about the entire topic. At your own convenience, you can look through it. There are live sessions as well, like the one you're discussing right now. And you can, you know, ask any questions you want, discuss with the teacher for live classes. Okay. We have express exam module, which is there, where you can cover the entire syllabus in less than 20 hours. There are one-to-one doubt clearing sessions, as well as hard copy notes tests, which are made available at higher subscription plans. And there is question banks of different difficulty levels. Practical sessions are also being recorded, which will be available to you in the app. And these are the various subscription plans which are made available. And you can use my code, Dr. Shakthinag 20, for discount on subscription. Thank you for watching. And these are the various social media handles of Auricle in case you want to communicate with us. So thank you for watching.
Start.